There you go.
Okay. So everybody can see, correct?
Yes, ma'am.
Okay, all right. So good morning. I can't see the students though, but I guess that's okay. All right, so good morning. We are gonna discuss metabolism this morning. This takes about a good hour and full session pretty much because we have a lot to talk about. I do tend to go kind of quick, so if I'm going too quick, you might need to slow me down. I just trying to make sure that you're getting the information that you need to be able to understand this concept and apply it to the exam. So anyway, so just bear with me, and if I get too quick, just let me know. But I think I do need to see you guys somehow, some way. One more time. Oh wait, here it is. Ah, we got it. All righty. Okay, so y'all, this concept this morning is extremely important. It's all about the survival, healing, getting well, and maintaining healthy living and homeostasis. Our metabolism is what controls so many things in our body as far as what we take in and out. So with metabolism, we're considering nutrition, and nutrition is going to be mainly my focus on this, is to kind of give you all the information you need to provide the needs for the patients that y'all will be taking care of. Okay. So this is out of the book, you guys. Metabolism describes the processes of biochemical reactions occurring in the body cells that that are necessary to produce energy, repair cells, and maintain life. So it's something that we absolutely need to function.
Oh,
I'm going to tell you that nutrients or nutrition is a basic component of health, and it's essential for the normal growth and development, tissue repair, maintenance, cellular metabolism, and organ function throughout the life. So of course, as we go through life, things change, but we still have to maintain our basic nutritional needs in order to have our bodies function the way they need to. Our nutritional status will also help our bodies repair what it needs to repair if we're in a good nutritional state. However, if we are not, it's going to take longer for our bodies to heal, or sometimes even complete delay healing. There are some pharmaceutical agents that are used to treat disease that affect with the foods that we take. So we need to look and see what medications the patient's taking. Is it something that's going to prevent the absorption of something, or is it going to interact with a medication you're taking? So you have to watch. Sometimes there are dietary restrictions with certain medications that are taken, coumadin being one of them. And we'll briefly speak about that, but I want y'all, it's on the Canvas site, so I want y'all to read that and be familiar with it. It's a very important medication that's often used, and patient teaching is essential, especially if it's a patient that's been newly diagnosed on Coumadin. So this is part of the reason why it's so important for us to know what medications our patients are taking. And the nutrition is the sum of all interactions between an organism and the food it consumes. And the GI system aids in digestion, absorption, organ function, and prevention of illness. So what if for some reason I can't swallow my food? What would my options be?
NG tube.
An NG tube, very good. What if for some reason my stomach has been altered and I'm not able to put anything into my gut? How do we get fed? That might be going on for 4 to 7 days. I'm unable to take anything in by mouth into the stomach.
Through the small intestine.
It's going to be a parenteral nutrition, which is going to be an IV we're going to talk about. But there are times that our stomachs cannot tolerate the enteral feedings that they will provide. So then we have to go to the next step, which would be to provide an IV. And we'll talk more about that. It's called hyperal or TPN, but we'll discuss that a little bit further. We already know what food provides: energy, right? like electrolytes. Let me ask this, what's the most important food that we have? Anybody? What's the most important thing that you take in every day?
Water.
Yes, very good. Essential. We have to have water. Must. Otherwise, our bodies will shut down. Not going to function like they need to. We do know that carbohydrates are an essential nutrients, as well as proteins, lipids, vitamins, minerals, and water. And the ones that produce our energy is the carbohydrates, the proteins, and the lipids. Do y'all know some examples of protein? If you have to have somebody on a high protein, they might have a wound and you need to promote healing and they're not eating very well, but you want to give them something that's high in protein. What would y'all offer? So if they could eat a normal diet, what are some foods that are high in protein that y'all might grab to eat quick?
Meats, nuts.
Say it again.
Greek yogurt.
Yogurt, okay, good. Eggs, peanut butter, fish, chicken, some cheeses, tofu. They have all kinds of foods out there. Y'all need to be aware of what which foods are high in protein. It might be you telling the patient that you need to eat more foods like this, and then you're gonna have to give them a list of protein. So be able to, identify. All right, so I might have switched a couple of my slides around last night because it wasn't flowing, but I think I'm okay yet. It might be the next one. So now that we've spoken a little bit about metabolism and nutrition, we're going to talk about what we're going to see in the hospital is going to be alterations in metabolism. And when this happens, it's usually a disorder of the structure and the function of the endocrine gland. And it alters the normal levels of hormones and the way the body uses these hormones. So when the hormone production increases or decreases, individuals increase alterations in health, such as diabetes, obesity, osteoporosis, and glandular disorders. I'm going to talk about obesity and I'm going to talk about underweight or malnutrition. Obesity is also referred to as overweight, undernutrition, overnutrition is what it's called. It's a different term, but anyway, so why do I keep doing this? Obesity is a state in which excess calories are stored as fat, 33% of adults, 17% of youth. These numbers have gone up. Do y'all know why that we have such an increase with the youth? Anybody? What are some of the contributing factors why our younger children are having issues with obesity and diabetes?
They're not going outside and playing.
Number one, lack of activity, not going outside to play. Why are they not going outside to play, some of them?
Tablets.
Wait, say it again?
Video games.
Video games. Okay, yes, video games. It could be parents not home. They want them in until they get home. It could be the fact that neighborhood's not safe. I mean, there's a number of reasons why this is taking place. And it's easier for parents too sometimes just to let the students, let their kids just, hang in the house. They don't want to deal with it. But anyway, let's see what else. So this is a picture of malnutrition and undernutrition. Do you think you will see this in the hospital? They might not look like that, but yes, you will see under and malnourished patients, okay? This is, as you can see, the visual inspection, your assessment right there, you can see some of the things that are going wrong. It's very difficult to deal with. I haven't seen it to this extreme, but I have seen undernourished and malnourished elderly patients because they lose the interest to eat and they will call it failure to thrive. So they just kind of stop eating and they just sort of waste away. We do try to encourage as much liquid. It's like a chocolate milk or a strawberry milk, the Inshores and the different protein drinks they have out there. So they at least drink that once a day. But sometimes that's even hard to get in. So what are these patients going to look like? So I just put up here some nursing considerations. So some reasons that can contribute to this is patients being in the hospital for certain amount of time. They're going to have some diagnostic testing done, procedures. They might be on an NPO status for a couple of days, or they could be on NPO because they're not able to eat or put anything in their stomach. They have a disruption of the absorption in the belly. They might not be able to swallow. It could be poor appetite. It could be that they're fatigued. There's a number of reasons why this can happen. And of course, the patients that are acutely ill have a higher risk factor for this, because it might be harder for them to get the food that they need inside. So anytime a patient is NPO for any length of time, I think it's between 4 and 7 days, they're going to start them with some sort of a probably IV fluids and possibly TPN to help meet their needs that are going to be prescribed by the physician. He's going to look at their lab work and he's going to write an order for the TPN, which is total parenteral nutrition. I'm going to cover it later, but do know that this is one of the things that could be implemented to get the patient in a better state, nourishment wise. Advancing diets. This happens, say a patient had surgery on her stomach and we can't just give her a hamburger right away. So we need to progress the diet gradually. And we'll talk about that in a few minutes as well. But we need to be aware that there are different types of diets for cardiac patients, diabetic patients, a number, hypertension, pretty much every disease, not I want to say every disease, most diseases do have some dietary restrictions, and we have to pay attention to those as well. What can we do to promote an appetite? What do y'all think?
Make the food look appetizing.
Yeah, that's a good one. How about make it something they want to eat? If we can do that, we should ask what it is that they like to eat and see if we can get that there. We also want to make sure it's an appropriate time to eat, that nobody just got off the bedpan in the other bed. Make it a social time. Have someone sit with the patient while they're eating, because eating is very social. So there's a number of things that we can do to help promote an appetite, to encourage them, make the food look good, give them something to drink to cleanse their palate, make sure that their mouth has been cleaned prior to, all those things. Y'all can look in the book, there's plenty more in there. And y'all, this lecture is in addition to the book, so you need to look at the book as well, okay? Because I might not cover everything. I try to, but I might not. Assisting, why do I keep doing this? Assisting with oral feedings. What does that mean, feeding them? Or does it mean assisting? You always assess what the patient's capability are. What are they able to do? If they are able to get the spoon to the plate, then we're going to provide them with a plate with a bumper on it so they don't spoon the food all over. But as long as they can get it to their mouth safely, it's okay. We want to promote as much independence as possible. You don't want to take away their rights to feed themselves if they're able to, even though they may make a mess. Pad the bed, put a big cover over the top of them so they don't make such a mess of everything. But you want to promote as much independence as possible. Spoon feeding someone at that point, they start to lose their dignity and maybe even give up because they're no longer able to do for themselves. So anyway, y'all want to keep that in mind. Just don't pull the spoon from someone and say, I'll feed you, because that's just not the best way to do it. Okay, these you do not need to memorize. I just want you to know that to be aware that they're there. You will see them referenced to. The dietary reference intake is what is considered the acceptable range of quantities of vitamins and minerals for each gender and age group. So it goes according to gender and then your age. The USDA dietary guidelines are just dietary guidelines. That's their recommendation of what we should be taking in on a daily basis. Daily values are the needed proteins, vitamins, fat, cholesterol, carbohydrates, fiber, sodium, and potassium. Don't need to memorize. Just want you to know that you do have these references to look back on if you have to teach. Most of them posted on a box or a label to kind of let you know where that product beats these criteria. Let me go back for a second. See y'all here. I want y'all to look at page 992. It's in my textbook, module 19. No, I'm sorry, module 14, nutrition. And the name of the box is the multi-system effects of undernutrition. And it's a picture of a body. And on the side of the body, it indicates every organ that's affected by malnutrition. I think y'all need to be aware of that. So study
Let me
that.
see, can you give me the page number again?
Yes, in my book, it's 982. And I don't have a figure number. Like sometimes they label them. It's not labeled.
Which book is it, Concepts or the Fundamental?
I think it's concepts, but let me double check. Hang on. Yeah, it's concept, volume 1, nursing. And my page is 1004, module 14. And I'll tell you, want me to tell you, wait, I just gave you the wrong number. Hang on. It's page 1000. That's the medicines. I'm not worried about the medicines. Look at page 996.
So which page number is it?
It's page 992.
It is page 992, but you could read a couple of pages behind it, but not in great detail. Just kind of get effect of what happens with malnutrition to the body. Not every little detail, you guys, you know the important stuff. Okay, we went through this. All right, so once we're doing our assessment, you guys, we have to understand what's affecting some people's nutritional status. What's going on? Are they able, where do they live? The lifestyle, are they living on the run, or are they living in their home by themselves and they don't have anyone to bring them food? So we have to kind of look at the history, find out what this patient has access to and what can you do to help. Economics, of course, is a big issue because if they cannot afford the food to buy, they're going to be on a limited intake. I mean, food is extremely expensive right now. And for people that don't have excess in money, might be buying just what they can buy with a small amount of money and trying to survive on it. So that could create a problem. And of course, medication and therapy, we know that can always interfere or, prevent something from taking place. Their general health, if they're in decent health, are they good health? Are they poor health? I mean, are they up and around? We got to look at how they're functioning. Also, alcohol consumption, it can be done in moderation, but it shouldn't be done on a daily basis. A lot of times alcoholics will tend to drink rather than eat, and then that throws their body into a state that's very difficult. And it also impairs their liver functions. So it gets to be complicated. Advertising. How many of you are affected by the advertising you see on TV as far as some of the food? Y'all ever see a commercial and say, I gotta have that?
Yeah, but it's mostly with food.
It's most what?
It's mostly with food.
Yeah, that's what I'm
That's
saying, food. Yeah, it's with food.
Oh yeah, you see a burger and be like, "Ooh, I'm about to go get it right now."
Yeah, they got a lot of things out there, but they need to have more commercials of the healthier options and make you tempted for that. But anyway, it's always the bad stuff. Popeye's chicken. We have to consider the patient's developmental factors. Are they able to understand what I'm telling them about a diet change, or is it a young child? Female or male? Sometimes females are a little more interested in learning than males. It just sort of depends on how it refers to them. We need to consider their ethnicity and their culture. I don't know what I'm hitting that's making us go. Oh, and of course, the beliefs about food. Are there some foods y'all don't want to eat because y'all believe something? No? They do have some people that do that, so pay attention to that. And of course, preference and then religious practice. Like right now in Lent, a lot of Catholics don't eat meat on Friday. I know that because I'm Catholic, but I don't know about the other religions, but I'm sure there's other things as well to consider. So these are just a few things that you might have to take into consideration when assessing your patient. So your actual assessment, of course, is going to be the assessment. Let me get to my page so I don't forget any notes. Okay, so initially you're going to do the head to toe of an assessment. There is a little thing in the book. It's called the nutritional screening. We can do this. It's a couple of pages. It's not the full length of a nutritional screening, which we really are not allowed to do. I believe it's a speech or a dietitian should be doing that, but we can definitely get the ball rolling if we see that our patient's height and weight and their physical appearance and nursing history indicates that. We can definitely suggest that there's an issue with nutrition. Their nursing history, you know, what's going on with them? Are they able to provide for themselves? Who's feeding them? We're going to take the anthropometric measurements, which is going to be the height and the weight, and calculate a BMI. And then we always have to identify the patients that are at risk for nutritional problems. Do y'all have any idea who those patients might be in the hospital, the ones at risk?
The elderly.
Yes, elderly, always elderly and the young, y'all, and the babies. Those are going to be at risk. But you're going to look at people maybe that have had brain bleed, subarachnoid hemorrhage, somebody that's unconscious, somebody that's maybe got a gunshot to the face and can't swallow. These are going to be the people that are going to have difficulty getting it in. If any issues with swallowing, chewing, or taking medications, there's going to be a problem. We're going to be looking at lab values. I'll tell you about that. I think it's the next slide. And then dysphagia is difficulty swallowing. And I'll talk to you about that too, because I have a slide for that. More health history. What are we looking for? Their current height and weight, their health status, their age. Are they allergic to anything? Are we using drugs or alcohol? Another important question is, what do you take at home? What herbal supplements are you taking? How often are you taking them? Where do you get them? And then if they're taking any over-the-counter meds, we always have to look at the whole picture of what's being consumed. Food, supplements, medications, maybe other people's medications. We always have to ask. And then another would be their mouth. If they're able to chew, swallow, and get it into the stomach, then that's a good thing. But what if they've had a stroke and they can't, they have difficulty swallowing, and then that becomes more of a problem. And we'll talk about that because that'll be something that y'all are going to see probably more frequently in the hospital. And then also if there's certain food that they're trying to avoid, we want to ask why. What does it cause? Oh, every time I eat that, I get diarrhea. Well, let's probably not eat that because if it's causing that kind of a problem. Or if I eat that, I vomit. So let's not eat that. So we're going to find out what the problems are with the foods because some people have food aversions for whatever reasons. But if it causes a medical issue, then it's important to kind of address that. This is the diet history. Y'all don't need to memorize all this. Just read it and understand it. What do you usually take in and out? How much do you drink? Where do you like to get your food? Who prepares your food? Buy all fast food, so that's not the best thing. We might have to teach them about making healthier options. Food allergies is important, their cultural background. Anybody eat food kind of related to their culture? I know we do. Yeah, it's a big New Orleans thing. So you have to consider that for some people because where they are might not be where their norm is and they don't have the food that they like. So we have to maybe try to get and accommodate them. Religious, the same thing. Socioeconomic status, of course, is going to have a direct relation to what they're able to provide. I don't know if y'all have noticed, but healthy food is a lot more expensive than the food that's not good for you, which is a bad thing. Psychological factors, their ability to obtain the food, and then also who shops for the food. Sometimes they can't get to the store, so they might have a neighbor going in and running and getting a couple of things for them, and that might be an issue. So But now we have all these nice services where they can deliver the food to your home, which is really nice. I think you pay a little bit more for that, but it's a nice privilege to have that. And I've used it a couple of times. And then another thing that you could do, because sometimes it's hard to remember what they ate. So just give them a 2-day day to kind of fill out a food diary. And that way you can see actually what's going in and out. Just these are the components to a nutritional assessment. Just wanted you to see the anthropometric. It's where they're doing the nurse and health history, physical exam, and it's useful in identifying malnutrition and other nutrition problems. So we're going to take a height, a weight. We're going to look at their ideal body weight and then the body mass index. So y'all, that's important. The BMI, we're going to look at the height and the weight. And you're going to come up with the BMI. And I know some people aren't going to be happy with the BMIs, because to me, the BMIs make everybody overweight. Anyway, that's how it relates to me. But anyway, not for everybody. And some additional in-depth, but this is not done by nurses. It's the tricep skin fold, a mid-arm circumference, and a mid-arm muscle circumference. These are done by people that are personal trainers and stuff. But that's when they do a complete assessment of your body makeup, and they'll be able to tell you what % of fat you have and lean muscle and whatever else. So it's good. I've not had it done. So this is what's important. This is the BMI. So everybody, look at how tall you are all the way to the left. It's in inches. It could be in centimeters, maybe, depending. And then you find your weight across the top. So let's say I'm gonna make this up. I'm 5'11", and I weigh in my dreams 150, 60. 5'11", 150. So what is my BMI? Can y'all see it?
I got 21.
21.
It's 21. Okay, so y'all get the idea on how to use this, correct? What I need you to do for the test is I want you to tell me what's 21. What range
It's
is it?
normal range.
So guys,
normal
remember
range.
this. Y'all have to remember this. Okay? Everybody knows how to do it? Height, weight, meet in the middle, your number, find out where it is, and I need to know what it is. Is this good? Is this bad? What do we need to do here? All right. Another thing we look at is our blood work, our lab. I'm catching up. Hang on. So the common lab tests that we're going to see are going to be the plasma proteins. And with that, you're going to look at the albumin, which gives you more of a long-term view, more of the, like over the 21 days. You don't need to know the norms. I think it's a good idea to know that the plasma proteins are looked at for this. But I'm not testing you on ranges and stuff like that. The pre-albumin is also, that gives more of a short view, like the past 2 days. So as you can see, we're going to be monitoring both of those as well as the hemoglobin. This is a complication of nutrition. This is dysphagia, and it is it's difficulty swallowing. And it's usually related to a stroke, cerebral palsy, ALS, diabetic neuropathy, head and neck or trauma, cancer, surgical resections, anything that can cause them from taking a swallow and it going directly into their stomach. Okay, so what happens is they have this thing called silent aspiration. So, you know, have you ever seen someone drink and it go down the wrong way and they immediately start to cough? That's an aspiration. They're trying to get that out of the lungs because it went down the wrong way. So this could easily happen with the elderly, could easily happen with somebody that's not fully awake. So you've got to be careful. They should be sitting up. Always the head of the bed needs to be up if you're giving someone something to eat or drink. I'd say 30 degrees. Safety is extremely important because these people can develop they can aspirate and then get pneumonia and then die. So we want to prevent it at all costs. We don't want to do this. Before we put something in someone's mouth, we need to make sure that they're able to swallow it. Okay. Speech therapies are the people that usually do that assessment. You might see a patient pocketing food in the side of their mouth, might be because they can't swallow it. That patient needs to be seen and assessed as to why this has taken place. So just keep an open mind. Aspiration is dangerous, it can cause death. Some of the nursing care for this is you are going to be, number one, worried about airway, always airway. If you're my student, you'll know that. I have an issue with y'all touching that suction equipment when you get in the room. It's part of your assessment. I want you to know that that suction equipment is on at the bedside and it's ready to roll when you need it. You don't need to go troubleshoot it when your patient's vomiting and inhaling it or aspirating and you're trying to troubleshoot it. It's not going to do you any good. So make sure, make friends with the suction canister, how to use it, the yanker, all of it, how to control it. Go introduce yourself to it. It's red, white body. Anyway, you need to know how to use that. It needs to be sealed and ready to go for suction in the event that it's needed. That will help clear the airway in the event that they have inhaled. Also, I said keep the head of the bed up. Let's see what else. You want to, before any of this, you want to make sure the patient's able to swallow. Of course, you're going to assess the needs, assess do they have any dysphagia going on that you might need to modify their diet or whatever. Usually if they have this, they're not able to eat, drink, or take medications. So we're looking for other options for that. There are tubes sometimes, and sometimes we have to start with the IVs if we have to. It just sort of depends on what their condition is. Hand washing, of course, is going to be important. Sometimes you can change the texture of the diet. I mean, we don't do this, speech does, but say if we're giving them clear liquids, we might have to thicken the liquids. If they're getting chicken and they can't chew the chicken anymore, we might have to puree the chicken so they can get it, but it's in a different texture. So we'll talk a little bit about the different types of diets in a little bit, but be aware that somebody with this issue is going to have to probably have a modified diet. We will maintain their weight, monitor their weight. We don't want weight loss to take place because then we're not meeting their metabolic needs. So that's what you got to do. Read the book on this. It's important. This is a complication that you will come in contact with, and it's best that you know exactly what you need to do, and it's an emergency situation. So it's one of my pet peeves. So I like for y'all to know and become friends with that suction equipment and know what this is, what to look for, and how to take care of it. A complication of this, y'all, I told y'all, is aspirating. And once you aspirate, it can grow bacteria in the lungs, and next thing you got pneumonia, and then you're in the hospital longer, and even if you leave the hospital. So it's pretty bad complication. So we try to avoid that from happening. Okay, moving on to something else now. That was the difficulty with eating. This is here what we can educate our patients about for them to make better health choices, to promote health and be healthier. We have some resources available to us. We do provide education and counseling. To the patients to prevent disease and promote health. Remember, y'all, it's all about prevention. We don't want to wait for the disease to be there. So we're trying to make healthy choices now. And with that, we have to educate the public. So back in 2020, we had a healthy people that was drawn up, and they have a lot of information in that. I think it's in the book. You don't have to read about it. I'm kind of more interested in the fact of you teaching these other options, which is going to be choose my plate, food labels, diet and exercise, and food safety. The Healthy People 2020 set goals for us, but it's almost dated now, but it's better than when it was. Okay, well, I want to go forward. So this is the way things were 20 years ago. And this is the way things are today. Do y'all see that? What has that contributed to? Our obesity. Everything's bigger and it might be cheaper, so they want you to buy it. They want to get you to, but they're not really worried about your health and wellness. So healthy eating is going to involve fruits and vegetables, grains, lots of water. This is my plate. I need to talk about this. So this has taken the place of the food pyramid. I don't know if y'all remember that, if y'all taken a health or a class on this, but we used to have a food pyramid, which was a little complicated to read, and it had all kinds of stuff in it. It was very congested, and they decided to revise this. The government decided to revise this so it would be a little more user-friendly for people to look at as a visual, and for them to maybe go to the grocery with this image of their plate in their mind, knowing they need to buy fruits, grains, vegetables, protein, and a dairy. Nowhere on there does it say potato. Nowhere on there does it say cake. So this, I believe, provides for age 2 and up between a 1,400 and 2,800 calorie diet. It's all about portion control and variety. One other thing. Give me a second. I can't remember the word. I need a strong cup of coffee. It's proportion. So if you look, the plate's cut up in 4, grains and veggies are a little bit bigger, proteins and fruits are kind of the same, and then you've got a small portion of dairy. So you can visualize this in your head. Like I said, for people that are going shopping, you can provide people a handout with this on it. They have multiple colors. You can even buy a plate that's labeled like this. So it helps people who are trying to cut down their sizes, or even those who are trying to eat. You want to get them as much as they can on that plate, to consume as much as they can on a plate, not 10%. You want them to eat at least 60%. Going back, notice there's only 5 items on the plate, Okay, here, do y'all read labels?
Yes.
A little more aware than you were before? So a problem with reading a label is some patients don't, not just patients, people will look at the nutrition facts on the side of the box and not pay attention to how many servings. So they look here and it says serving size, 1 cup. Okay, 1 cup. Then they come down here and they say 1 cup equals 43 carbs. And I have 9 proteins. Is that correct? Why isn't it?
Because it's 2
There's
servings,
two
so you should cut it in
Thank
half.
you. So important is the percent. How many servings are in the box? It might be a little box, but it might say 4 servings. So that means your portion's pretty small. But the patient needs to realize if they eat the entire box, they need to double this. Or if they eat half of the serving, to cut it in half. So you might need to educate them. And then I would give them a label to make sure they understand it, because sometimes it's difficult. So this is definitely a teaching tool here. For something to be considered low calorie, you guys, I think it needs to be 40 kilocalorie, 40. Wait a minute, I wrote it down. I think it's 40 calories for it to be considered low cal per serving. Imagine that, 40 calories per serving. That's considered low fat or okay to eat. Going back to that again. All right. So these are the fruits and veggies. I thought it was a pretty picture. Took it. This is what we need to encourage people. This is what we should be eating every day. Could you imagine cutting all that up? Pay somebody. All right, exercise. Can everyone exercise? No, they can't. So we need to make sure that it's okay with the physician that they can exercise. It needs to be, moderate. okayed by the doctor, and you don't want them to work out to the point where they're totally unable to speak and they're lying down on the floor. It has to be within reason. If they're going to start off with not being active before, they need to start off slow. Lots of tips for initiating exercise. And I'm sure you can apply what you've done for yourself to a patient. Just make sure that you're teaching them right. Don't tell a 300-pound man to go out and run 10 miles. Not a good idea. Okay. How are we doing on time?
It's 9:15.
Let's do this activity and we'll take a break. So what I want you guys to do is pick your favorite fast food meal, your favorite one, the blowout of all. Look at the caloric intake, the fat, the carbs. Give us a little nutritional update of what it is. And then if you have time, I'm going to give you like 5 minutes. Look at what the unhealthy options, the healthier options are. So we're going for what's your favorite? And then what's the healthier option that's at the same place? It's fast food. And we'll get a few people to share what they learn, if y'all don't mind. So I'm going to give y'all 5 minutes to do that. This is nothing serious, just a little fun. It's supposed to be a raise awareness. I'm going to set my timer.
Hey, I have a quick question for you.
Yes?
Is there the notes that you put for us today is not in a document form? So basically in order for me to print it, I had to take screenshots of it and print it out, and I can't edit it. Can you maybe repost it as like a doc or a PDF or something?
It's not
like
in
that?
Word?
No, ma'am, it's not.
That's so weird. Yeah, let me look at it.
I
wonder-
appreciate it. Thank you.
I put it in Word, so I'm kind of confused as to. I'll look at it.
I had to convert it to a Word document. I think it's saved like as a PDF or something.
You were able to convert it?
Mine was a Word document.
Yeah.
I printed it.
Yeah, mine was a Word document too.
Ooh, I don't know what happened in that case. Sorry, y'all. Kristen, I'll send you my
All right. That's up. Time up, y'all. What did y'all, anybody want to share what they found? Not everybody jump up at once. Come on, we got any Popeyes, Taco Bell, Cane's Chicken, Burger King, McDonald's, Pizza Hut? No? Okay.
I eat Moe's, and I'm
Oh.
allergic to, but I'm allergic to a lot of things. And so like I'll get the bowl with the rice and the beans and then the meat, whatever meat I pick. And then I don't do cheese because I'm allergic to dairy and some other things like that. And so probably the worst thing would be maybe the sauce that I would put on top.
Mhm.
And then maybe too many of those greasy fried chips because they're so good. But then I will say it's probably too many calories at one time. So it's a little bit higher in calories than I thought, but
Right.
so what I do is I try and split it up into 2 meals as opposed to just
Good.
one.
Yeah. So you're not splurged, you're not depriving yourself. You're just eating a smaller portion. That's okay. It's acceptable. As long as you're not eating those portions 10 times a day, you're good. Anyone else? Y'all really didn't do it? Come on.
People are putting stuff in the chat.
Oh, I can't even see the chat. They're probably saying, hurry up, Miss Duplashane. Nuggets and fries, 6. All right. So I guess y'all don't want to talk. All right. Do y'all realize that the healthier option is almost as bad as the bad option? Do y'all see that?
Most of the time, yeah.
Yeah, that's kind of like the point of this is like, yeah, I'm going to be good and I'm going to get this instead of what I normally get, but you're really not doing yourself a favor. But anyway, all right, then let's move on. Yeah, here I go moving on and I can't get the slide to the. I'm trying, y'all. Okay, so we did that. That was no fun. Okay, now this is even more no fun. Okay, so y'all, this is when the patients have problems meeting their needs metabolically, if I could say it right. So there's an issue usually with swallowing or getting it into the stomach. And so what they'll do is they'll start a nutrition, which will go into the GI tract. So sometimes these tubes are placed through the nose, times through the mouth, and also through the stomach. Each of them have a different name, and I'm not going to go into all that right now because I think the gist of it is that they're going to be getting fed into the GI tract. Let's see, it provides physiological, safe, and economical nutritional support. A problem about it, what could happen is we're, putting this stuff into their stomach, this nutrition into their stomach, it's liquid. And what if they're lying down and they start to cough? What could happen? They could aspirate once again. So we need to be careful. So if they're receiving any type of tube feeding, you need to keep the head of the bed up. What else do you need at the bedside? Because they're coughing, they could aspirate. What's the other thing?
Suction.
Suction, yes, please. Suction, make sure it works. You have to have that, y'all. When the patient starts to vomit, it's not the time for you to start troubleshooting your suction equipment. It's stuff that needs to be on. Learn how to use the little yanker that goes with the tubing. Put your hands on that. All right, the aspiration, I told y'all about that. That could cause, it's called the necrotizing infection. So it's from the bacteria, from the high concentration of the sugar that's in the supplement that we're providing them, can cause a bacteria, and it can actually lead into the what is it called again? I forgot, y'all, necrotizing, which is not a good thing. So we want to prevent that at all costs. They can also get pneumonia, as well as potential for an abscess formation. It's a high concentration of usually blood of glucose, so we need to be careful with bacteria. The bags can't hang for days. There's certain criteria that needs to be followed by the hospital policy. So of course, any of these patients become higher risk if they are coughing, vomiting, if they have reflux. If you decide that you need to suction them nasotracheal, meaning you're putting the tube down their throat, chances are they're going to gag and whatever's in their stomach's going to come up. So I would then hold my tube feeding probably 10 or 15 minutes before I went in to actually suction, plan my care so then I can take care of the patient safer. And that way the stomach, the is somewhat down in the stomach. It's not right there up in the esophagus. Sometimes they have an artificial airway in, which could also cause them to gag. So you just have to be careful, make them comfortable. And of course, if their level of consciousness is impaired, you need to make sure that they're sitting up, always the head of the bed up to provide safety. Another thing is you need to make sure you have to measure whenever we're given. So the doctor's going to order, say, Ensure to be infused at 75 an hour all day. So about 4 hours in, my patients were receiving the tube feeding. So it's time for me, say 4 hours in, I need to go check to make sure how the patient's residual is in their gut. So I'll stop the feeding. And then I will aspirate a big syringe full of what's in the stomach. I need to pull back. If I can pull back more than what I'm given an hour, that's probably a concern. So if I'm pulling back 150, that kind of indicates to me that this patient might be getting too much per hour and their stomach isn't moving it along like they need to. So we might need to call the doctor and tell my residuals are high. And they'll say, most likely back up, let it stop it for an hour, back it up to 50, whatever. They're going to give you an order, but you do need to let the physician know. This is part of the independent nursing practice, is to check the residuals on this tube to make sure the tube is in place, because we don't want to just infuse supplements into, what if it's in their lungs and we fill their lungs up? So once these tubes are placed, X-ray confirmation is essential. That's the only way you're going to know where that tip of that tube is. So we have to make sure, and it's X-ray. The other method, which I haven't seen in UMC, I'm teaching it, but I haven't seen it in practice, is when they actually test the gastric secretions with a pH stick, but it's hard to find pH at the hospital. I've not seen it. So we look at the X-ray to make sure it's where it needs to be. And then we're going to make sure the tube hasn't moved. And then we're going to do a further assessment, see what the residuals are, see how they're tolerating it. Are they coughing? What's going on? So anyway, safety, because you do not want to fill someone's lungs up with this thick milk secretion supplement. All right. And the name of the suction is called pharyngeal airway suction. That must be at the bedside. So it's mouth and throat. So this is what it looks like. These are the little tube feedings. This top tube here, we as nurses put this in. You'll learn that next level. It's kind of it's not as difficult as you think it is. But we do need to, once it's placed, as you can see, they have the little radio opaque markers on it. Then they will get X-ray to make sure that this is in the stomach, not in the lungs, because it's easy to go down into the lungs. So it's essential before, and anytime you start this, you need to make sure that the tube is in the proper place. Because say that you come on night shift and this tube is no longer taped and it's further out, and then you start to instill that and the patient's coughing, it's because the tube's been pulled out, it's in the airway, and you're filling them up with Ensure or Jevity or whatever it is. Okay, this is I'm sure some of y'all have seen these. These are the little bottles that they hang at the bedside. There is a protocol. They're probably only good for 24 hours, but each hospital has a different policy. We don't want to let this hang for too long because bacteria can grow. Bacteria can grow in the tubing, and then we can cause a problem with the patient. So this is NG, nasogastric. This here is going to be G-tube or digostomy tube. The G tube is going to be the one right here in the stomach. We will see these in the hospital. Y'all, if you have a patient that's receiving feedings through a G tube, ask your instructor to show you, to teach you about it, because all I can show you, I can show you what it looks like, but you need to actually see it in person to understand it. So it's a rubber tubing, but give me a second. I'm gonna get to the next slide. This is a pump. We put this all on a pump. If we don't use the pump, we can do it by hand. It might be, you need to give the patient 100 milliliters every 4 hours. So you're not going to use a pump. You're going to go in and you're going to pour in the 100 milliliters and let it go in by gravity. And I'll show you what that looks like. But for this here, it's on the little pump. These would be called kangaroo pumps. I'm not sure what this looks like, a patrol, but so you're gonna have to get familiar with this. It's just a matter of setting the rate. Okay, so this is the nurse that has the order to administer it, a bolus of it every 4 hours. So she's gathered all of her equipment, and then she's given the patient in the tube directly into the nose. And before she did this, she checked for placement. And listen, once she fills this syringe up, the higher she holds it, the faster it goes in. Do we want to hold that in fast and have that rush into the patient's stomach? No, not a good idea, because chances are it rushes in that fast, it might rush right back out. So you want to let it to kind of gradually go in. I'm not saying 30 minutes, but you know, hold it up enough to where it's just kind of like she's drinking it. Okay. She's wearing gloves. She's got the bottle she needs. All of this is what she needs when she's doing that. And you'll figure that out at the bedside. This is what it looks like if you do the verification of placement with a pH paper. It's out the book. Like I said, I have not seen it in practice, but I heard it was there. It'd be nice, but we're just not there yet. So this is the percutaneous endoscopic gastrostomy. This is what they call a G tube. It's put into the stomach. It's rubber, pliable. All you're going to see is this little bumper on the skin, a clamp, which is extremely important, and then a little bit of tubing, and then the tip. So this goes directly into the stomach. So does this need to be kept sterile? Sterile or clean?
Sterile.
It's going into the stomach. Is the stomach sterile?
No, you can't have it sterile, so clean.
That's correct. You understand? This, I mean, I would wipe it with alcohol, but it's not going to be considered sterile because this is going to be connected to a syringe. Tube feeds are going to go through this. You want to keep it as clean as possible. Once this little thing has been placed inside the patient, initially they put a little dressing underneath it to kind of, if there's any blood, but after that, the patients will go home with this tube and there's nothing on the site. So it kind of heals up. It looks like almost like a belly button, but it's got a tube in it. And it goes directly into the stomach. Patients can pull these out because they're rubber like the catheters. So all they need to do is pull on it. This is going to bend up because that's how they put it in. They put it in percutaneously. They stuck it in and it popped out. So all they need to do is pull it back out. Yep, they might have some bleeding, but do we put the tube back in? Nope, not ever. You call the doctor, okay? So your responsibility is to maintain this, make sure it's clean, and then to provide the feeding for the patient. Okay, if they pull it out, call a doctor. Cover it up and call a doctor. G-tube, y'all. Okay, this now is parenteral nutrition. This is for the individuals that can't take anything into their stomach. They can't swallow it. For some reason, their stomach is not digesting, absorbing. It's not doing anything it needs to do, or they have it on rest for a certain reason. Usually been without food 4 to 7 days, and then they'll start on this because our body will start to shut down if we're not getting the appropriate electrolytes and the nutrients and everything that we need. So it's called hyperalimentation, also known as TPN, which is total parenteral nutrition, parenteral meaning vein. There's 2 types. The little white bag is called intralipids. And then this bag here is considered the TPN. Most of the time, if it's yellow, that means it's got a multivitamin in it, but that might not always be 100%. but this is strictly fluid and electrolytes. Wait, I didn't mean to do that. There's no medication in this big bag, okay? The doctor writes this order for this bag according to their lab work. They're monitored very closely. This could cause them to go into hyperglycemia because it might be high in sugar. So we have to monitor our patients. It also has a lot of glucose in it. Therefore, it's highly likely to grow bacteria. So any patient that has this type of an IV, meticulous IV site care, keeping the patient clean, changing the tubing as needed, wearing gloves, using alcohol preps, following all protocols. Because guess what? If this patient gets an infection from this bag, say this is the bag, and it follows the line, see the line? Where is it going? Do y'all see? This is considered right, it's a central line. The tip of this catheter is in the superior vena cava. They just slightly put it right in there, and that's a good spot to infuse this not medication, IV fluids, okay? But this is this is called a central line. They have them in different areas, but when you do this, you're gonna wear a mask, sterile gloves, you're gonna cover the patient's face up, and this is gonna be a sterile dressing change. Okay, so this isn't just the little wipe down IV site. It's a central line. They have them in different places in the body. It's a wonderful place to dump fluids if you needed to. Like patient was bleeding to death, you can put a lot of, because the line is relatively big and you can get it in there. This is being used right now for long-term use for this patient that's having to get this parenteral nutrition. Y'all get that? Dressing's gonna be probably up here. Sometimes they can insert it in the brachial, but not that often. You're seeing them more up in the upper arm or the neck. But anyway, once again, this here, you're going to check it like blood when it arrives on the unit. You're going to check it with another nurse to make sure that what's in the bag is what's been prescribed. You're going to compare it to the order before it's initiated. And then the intralipids sometimes go with it. They run those, not all the time, but that's just a little white bag. It looks like milk, but it's fat emulsion. I'm going backwards now. Okay. These are just some of the complications. Infection, pneumothorax, when they're actually inserting this because they're going subclavian most of the time, and they could accidentally nick the tip of the lung, which would cause it to drop. Your patient would then become short of breath, become anxious. So O2 sats are going to drop. They're going to get uncomfortable. You're going to witness that patient lose one lung with breathing, and you're going to see signs of distress. So the procedure needs to stop. The lung needs to be taken care of immediately so the patient can get comfortable and they can get that lung reinflated, and then they can proceed with this procedure. I have seen it happen, but it doesn't happen often. And it became kind of an emergent situation. But anyway, so these are the different sites that they can put these IVs in, central lines. Sometimes you'll see a PICC line put in, and those lines can stay in for about 6 months. But remember, meticulous nursing care to these sites, because that's your responsibility. You need to assess for any type of infection. And then when and if you do remove this catheter, you have to measure it, because what was put in was measured. And when you take it out, if you take it out, we used to take them out. So we had to measure it to make sure what was put in was put out, because we don't want to somehow, maybe a piece of it could have been nicked off and floated off. So we always measure it and inspect it, and then most likely send the tip for a culture and sensitivity to see if it grows anything. Important information. Okay, y'all want to take a break? Let's do a 5-minute break.
Thank you, Andrea.
You're welcome. You can tell it's my first lecture. I'm kind of slow. I apologize to all of my nursing students. I really need a very hot cup of strong coffee.
Well, one of my friends swears by the medicine ball that they sell at Starbucks.
A medicine ball?
Yeah, you can look it up online, but when you go to the reviews online, someone says, well, it's overpriced lemon juice. But one of my friends that's a teacher in elementary school, she swears by it.
And what's it called?
Medicine ball.
It's
And Starbucks.
I will tell you though, it has sugar in it because I used to work at the Starbucks. And so it's basically like hot lemonade, hot water, and then there's like 2 types of teas that they put in it. But then you can either put peppermint or like honey, but then both of those have sugar.
Yeah.
What doesn't? Everything at Starbucks has sugar.
No, I get I get the
Black
chai
coffee.
latte and just add Splenda to it.
But the latte doesn't have sugar in it?
Mm-mm.
Milk?
Yeah, I do half and half. And that cuts down on your carbs from like 50 carbs to 5 carbs when you do half and half.
I just need the caffeine in a cup. I don't think it would taste very good, but something to wake me up. I stayed up late reviewing this lecture and I want to fix it.
Well, you do well.
No, it's just, I know it's kind of, it's a little bit redundant. I got to get rid of some of the information, but it's like, if I don't teach it, will they read it? And I don't know.
Hey, Harley is saying she makes the medicine ball at home.
Oh, can she share the recipe?
Let's answer her.
I've never even heard of that. I might go to Starbucks today and get me one.
Oh, she says she'll give her a few minutes and she'll write it out for us.
Oh, she's
Thank
awesome.
you, Harley. Oh, we're supposed to be on break, guys. I
Yeah,
will probably switch to my phone after the break.
that's fine. I'm going to get something to drink real quick.
Hey, if you go to Starbucks, it's called the honey citrus mint tea.
Oh, that sounds good.
Yeah.
That's the actual name for it.
Wow. Stop. Hey, are y'all there?
Yes.
I'm here.
All right.
Did you tell them what time to come back?
No, I just said 10 minutes, I thought, or
Okay.
5 minutes.
I can't remember.
Yeah, I'm not used to doing this. I hadn't lectured last semester, so I feel like I'm a new lecturer. I'm nervous. Y'all students are making me nervous. Although I don't see half of them, but I'm going to go ahead and proceed. I'm going to go back to parenteral nutrition because I have some notes on my page that I didn't share. Can y'all hear me? Okay. All right.
Yeah,
So-
you're doing great.
Thank you. I need those words of encouragement. I appreciate that because I'm not feeling that way. But anyway, so y'all write some of this stuff down. Complications of putting this parenteral nutrition line in can cause an air embolus, meaning that the air gets in the vein while they're putting it in, or it could be in the tube in itself. And we don't want air floating around in our body. So we don't want to, that's a bad thing. We can have a catheter occlusion. And sometimes this happens. It's like that maybe the line wasn't flushed properly. Might not have been flushed for a period of time. So sometimes a little clot can form at the end of it. And then now the line is no longer useful. Some people will go in there and try to push the clot, aspirate the clot or whatever. I don't think that's safe practice. If I were to flush it and I met resistance, I wouldn't push any further because I'm fearful of throwing a clot and then causing a problem. So I wouldn't do that. Let's see what else can happen. You can also have electrolyte imbalances due to the electrolytes and all the trace elements and whatever else is in the big TPN bag. Remember, there is no antibiotics, there's no medication in it. It's just nutrients, vitamins and minerals, and that's it. No antibiotics. I told you your nursing care was very important. This is a central line. You need to check the order to make sure what you're giving is what's been prescribed. And you always inspect the site and the bag. Okay. Safe administration depends on appropriate assessment of the patient's nutritional needs, meticulous management of the central venous catheter, and also monitoring to prevent or treat any type of metabolic complications. And the goal for the patient is to get him from the parenteral nutrition to enteral, meaning we're going to get rid of the IV and we're going to give him maybe some NG feedings for a couple of days and then hopefully progress them back to food. But it's going to take a little bit of a process. So it's a progression and we have to go step by step. We just can't all of a sudden take something out and then give him a hamburger to eat because that's not going to work. We need to take it slow because remember the stomach might be healing from something. All right. Oftentimes these people that are on parenteral nutrition will not be discharged home. They end up going into a long-term care facility. So that's why it's the goal for us to get these patients back to their previous state if possible, or even to enteral feedings. It would be much safer than this. So just so y'all know. I don't know that you'll be taking care of any patients this semester with this, but I think y'all should go look for a patient that has it so y'all can see what it looks like and get an idea. I'll look for them for my students, but I don't know about your instructor. So that's the chair on it's the chair making noise. All right, so now we're going to talk about restorative and continuing care. Just like I said with that patient, we're going to want to move them back to a enteral feeding as opposed to the parenteral. There are other nutritional problems, not nutritional problems, there are other disease processes that you might have to change their nutritional intake. It could be kidney disease, cardiac, could be cancer, there could be a burn patient. So you have to be careful with what's going on with the patient to provide them with the appropriate nutrition they need to heal. So we have to take that into consideration. We will not be the ones prescribing, the doctor will, but he will also discuss with speech oftentimes, as well as dietary, a dietitian. So they're able to, because we don't prescribe diets. We give the diets that have been prescribed, but that's as far as we go. Wonder why this isn't working. Okay, so y'all, this is pretty simple, very straightforward. It's in the book. I advise that you look at the book, because this is something you're going to need to know. Could maybe next week you go to the hospital and your patient is on a full liquid diet. What's a full liquid diet? I don't have any idea. So you're going to have to look it up. But once you're a nurse for a little while, you're going to know full liquid, clear liquid. You're going to know what the food is. Make sure what's been ordered is what's on the patient's plate. Okay. After surgery, they'll start patients on clear liquid. If they tolerate the clear liquid, they might move them to full. And if they're doing okay there, they might jump them to food. It just depends on the doctor's preference with surgery they had. But this is usually the progression that it goes in: clear to full, and then usually to regular food. Pureed is for someone that's having problems chewing, mechanical problems. Due maybe to dentition, lack of dentition, could be a number of reasons why they're having a hard time chewing the food, so they'll soften it. It also makes it a little bit easier to swallow. Mechanical soft, look at what some of the examples are of that. It's going to be like mashed potatoes, macaroni and cheese. I want y'all to look up and be familiar with some of the food items are in this. In pureed, mechanical soft, what's a high fiber in a regular diet. Know what a clear liquid is and a full liquid. A question: a full liquid diet would include which food? Select all that apply.
Open the door. Yeah, I'm leaving in just about 15 minutes. Thank you.
Hey, y'all, is gelatin, would that be considered a full liquid?
Clear.
It's clear, but it falls on full. Anything on a clear liquid can be on a full liquid. It's just that it's clear. But not everything in a full can go on a clear. In order for it to be clear, you need to be able to see through it. Hold it up to the light. Can I see through it? Iced tea? Yes. Coke? They say yes. I don't know if you could see through Coke through a lot, but I've heard it was considered a liquid. Clear liquid? No. Clear is going to be apple juice, water, probably chicken broth. All right, so gelatin is considered a clear liquid. What about a popsicle?
Yeah.
When it melts, it should be clear, unless it's a milky popsicle, but these are not the kind of popsicles I'm talking about. Then, darn it. Ice cream, that's a full liquid. What's cream potatoes?
Down there in the bottle holder. Okay.
Is cream potatoes a liquid?
Mechanical, wouldn't it be?
Yeah. So D is not correct. What about a milkshake?
I would say yes. Full.
Yes. Okay. Y'all get familiar with the items on those different diets. All right, we're going to move to obesity. This is our exemplar. This is it's a fact of our times today. Y'all have any questions about what I presented before? Okay. So y'all going to get more details about obesity next semester, but I'm introducing it to you. It's called overnutrition or obesity. And the little thing says, why is America getting fatter? And it's because they are increasing the portion sizes, making them less or more appealing to the consumer. It's easier to get. People are working hard. So it's just quicker to go and drive through and pick up food. As you know, the healthier options are more expensive. What other reasons do we have obesity? People working too hard, too much stress, they're not exercising. And as you can see, it stresses just about every part of our bodies. We have problems just from carrying the extra weight.
We eat processed foods instead of fresh food.
Correct. Our body doesn't recognize that as food, so it ends up messing, yeah. There's a lot of contributing factors to that, but anyway, consider that. And of course, we're having the highest incidence of child obesity since forever. And it's due to the games, the gaming, the lack of eating fresh fruits and veggies, not going outside to play, all the video. The students really, I mean, the kids just are so addicted to the cell phones and the video games. It's not letting them go outside to do what they need to do. Those items should only come on at night. That's what my thought on it is. You can only turn them on when the sun's down. Get outside during the day. So basic overview out the book, you guys. Obesity is an excess of adipose tissue. And we know where we get that from eating too much fat, not burning the calories. It's the most prevalent preventable health problem in the United States. So this is where we need to be teaching prevention before it gets too bad. And it's hard, but get it, you know, it's just, it's making life choices. It has serious physiologic and psychological consequences. It's associated with an increased morbidity and a mortality. And 35% of adults in US are obese and 17% of the children are. And I'm not even sure that those dates are recent because it's been a little while. All right, so the cause of obesity occurs when excess calories are stored as fat. So whatever I'm taking in, I'm not burning, so it's storing it away. I got a little storage I need to get rid of, but I'm working on that. Complex systems regulate the food intake, the energy storage, and the energy expenditure. So this is what it's about, what you're taking in, how you're storing it, and then how you're burning it. Our appetites are regulated by the CNS and our emotions. How many of y'all are emotional eaters? Who eats when they're happy?
Me.
Who eats when they're sad?
I do.
I eat when I'm
I eat less when I'm upset.
Oh, I wish I had that
Really don't
issue.
have an appetite.
Yeah, that's it. I think it's good because I need to lose weight, but it might not be good. What
Right.
about those? Who's eating while they're studying?
That'll be me. I eat when I'm bored.
Oh, when I was in nursing
No, I
school,
eat when
y'all,
I'm
we had a food fast. And I came out of the nursing school weighing about 30 pounds more than when I went in. It was terrible.
Oh,
We were
wow.
eating horrible. It was like, it's so stressful. We thought it was okay to eat, not. Anyway. All right, your hormones are involved in regulating obesity, and this could be the thyroid hormone, as well as insulin and leptin. Risk factors, genetics, heredity, contributes 25 to 45%. Physical inactivity, environmental factors, and psychological factors. This is all the things we need to consider when we're trying to treat someone that's obese or overweight or overnourished. We're non-judgmental, but we need to help identify some of the issues that's taken place and what we can do to help rectify. If they're ready. If they're not ready, we can't do anything really. Some clinical manifestations. Some of the contributing factors for this, you guys, is that the treatment is complex. It's not easy. It's not overnight. It's long-term. It takes a while. It's complex. It's intense, and it's an ongoing process. It's not gonna end by the end of discharge. This is gonna go on for months to, if not years. They have to make changes in their life choices and what they're previously done. So it's an ongoing. We need to provide them with the support and the resources needed so they can be successful with this. But once again, we need to have their buy-in. They got to be interested if they are wanting to do this program. I mean, they're not going to just say, okay, yeah, I'm good. I'll lose the 40 pounds. It's very challenging. We're going to also, of course, an individualized program is needed. It needs to be specific for that particular person, because otherwise they're not going to feel that it's for them and they're not going to be interested. Morbid obesity is greater than 40 kilograms per meter square or greater than 200% of ideal body weight. So that's pretty significant. And at that point, you guys, these people, it's hard for them to exercise. It's hard for them to move. They have joint pain. So it's like, how can you get them to exercise and sweat and increase their heart rate when they're having all this pain? So it can be a challenge. So the effects of obesity on the cardiovascular, it is a serious, significant risk for disease. 60% have metabolic syndrome, which includes diabetes. I can't, off the top of my head, I can't think of what the metabolic syndrome is, but there's a couple of illnesses that go along with it. You're going to get that next semester. My brain's not as sharp right now. We're going to also see increased risks of insulin resistance and type 2. So what's going to happen is their insulin isn't going to be producing like it needs to, and it's not going to react to the amount of glucose taken in. And this will affect reproductive health. So if you're looking to have a baby, you might need to drop some weight. For some complications for obesity, what tends to happen, they're higher risk for developing gallstones, types of cancer, osteoarthritis because it's hard on the joints, depression because their self-esteem is low, sleep disorders, they might have sleep apnea, they can't get comfortable in the bed, just stress incontinence, too much weight, it's hard for them to get to the bathroom in time, and of course body aches and pains. It says low back, but it could be knee and hip and anything else. And always post-op complications. They have delayed healing. It's just harder. Recovery time is a little bit longer. So we're going to collaborate with the team. This is what we're going to do as nurses, and we're going to focus on reducing some of the health risk and try to change the eating habits and their exercise habits. So we're going to have to teach about that, but that's not just coming from us. It's going to be coming from physical therapy, the nurse, the doctor, maybe speech therapy, whoever else is in there seeing the patient. They're going to all encourage this because they're going to all be on the same page. Some of the diagnostic tests we're going to see is they're going to do a BMI. I'm not asking you to know how to do the BMI. I just want you to know what the BMI and where does that put them. Is that normal, abnormal, morbidly obese, obese? And the scale is on the BMI chart. This is the anthropometry measurements. We spoke about that earlier. Underwater weighing, bioelectric impedance, waist circumference, and other tests. These are lab work. Y'all don't need to know this for this semester. Just be aware that these are going to be some of the things that you might see. Okay. Pharmacologic therapy. This is for individuals that have exhausted all their diet options. So they do have medications out there for individuals to try to help suppress appetite. I'm not too sure of the success of them, but they have amphetamines and non-amphetamine appetite suppressants. Phentermine one, Sibutramine another, which is called Meridia. I remember when that one came out, but it was a long time. And Orlistat, which was Xenical. I don't know. I don't have any data on that to see if that's been effective or not, but it's obviously something that's out there for people. I did see on the TV the other night that there is a new medication. I can't remember the name of it because they have so many out there. Sometimes I feel like I'm watching a PDR commercial when I'm watching TV. There's so many medications. But it's a new one out to help with weight loss. So I don't know the name of it, but I'll look into it. What was the last thing? Bulk forming agents. That's over the counter. That's stool softeners, taking a lot of fiber to actually go to the bathroom. We need to encourage exercise as long as it's been cleared by the physician. And our goal would be for them to get 30 to 40 minutes, 5 days a week. But we could certainly start at 2 days a week. You got to start somewhere. As far as the nutrition advice, we need to collaborate with the nutritionist. We want to create a diet, 500 to 1,000 calories. This would be a good idea to help the patient do this because you want them to pick the foods that they like to eat to not deprive them. So you might be able to give them a snack or something that's a treat as long as you remain within this. So it's a good idea to develop this plan with your patient. Low calorie, low fat, high in fiber is the goal. And we're looking for a very low calorie diet for anybody with a BMI greater than 30. That's your lunch for today. It's healthy eating. All right, the behavior modification. This is probably the most challenging. It's critical. A way we can do this to make the patient aware of what they're actually taking in is to ask them to do a food diary. That way they can write down, you know, when they're eating, what they're eating, and to see if they can relate it to a specific time so we can make a plan to avoid that or provide them with a healthier option at that point. It's good for them to be able to eliminate the cues that precipitate eating. For me, it was an exam. If I had an exam, we were having a party. We're going to have all kinds of stuff. We had a group of 4 people and everybody brought something. It was crazy. But that was many years ago. You need to examine the factors that affect the eating behavior. So it was stress for me. Everybody's got their own triggers. Some people don't have an eating disorder, but many do. So it could be just lack of eating as well. But right now we're focusing more on the opposite end of that. But another thing is, which is important because they're going to leave the hospital, is you want to give them social support. You can give them information about some resources on the internet. You can give them some in the community. You'll be able to pull that off the internet and give that to them to take with them. So they'll have it to refer back to later when they're ready. But it's, you know, they've got programs, Weight Watchers, they have a number of places that offer this type of support and guidance and have been proven to be successful. So that would be something to encourage. Okay, so now this is the last ditch effort. Nothing else has worked, or maybe we've lost 75 pounds, but we still have 200 to go. So maybe this patient might qualify for bariatric surgery. This is when the BMI is greater than 40 kilograms. And there's a couple of different types. One is called a restrictive malabsorptive procedure. And it's where they bypass the portion of the small intestines and they have rapid weight loss. So with that, we're not getting the absorption of all the vitamins, minerals, and elements that we need because it's being bypassed. So these people are going to end up being on supplements. I don't know what that, maybe that's the, could that be the sleeve? No, I don't know if that's the sleeve. I'm not sure what that one is. Might just be bypass. Then there's the restrictive procedures where it's safer, generally less effective in long term. And I believe those are the sleeve, the lap band. It's actually puts a little band around the stomach to where they feel full quicker, which prevents them from overeating. So I think that's been a little bit effective, but I'm not sure if there's other new methods. I heard there was a ball that came out that they inflate in your stomach and it makes you feel full. But I don't know the medical term for it. I just heard people talking about it. But anyway, so there is options for surgery, but I would consider it pretty drastic. And then of course, the complications for the surgery are high risk. Death can occur and has. You got to realize that their bodies are not getting what they're used to, and they have to be monitored very closely, especially if they're not taking in the proper portion sizes with all the nutrients needed to function. What do? We're going to promote healthy eating. We're going to encourage children and adults to maintain an active lifestyle. Our assessment, we're going to look for risk factors, family history, any recent weight gain or loss, perceptions of weight and health, what's their diet and food intake. And then we're going to look at them physically, vital signs, height and weight, and skin fold measurements. So it's subjective and objective information. Objective is not enough. We need both to make this a solid problem that we can rectify. Our diagnosis for nursing care plan would be, these are just the potential ones that we have. It's imbalanced nutrition, more than body requirements, or it could be less than body requirements because they have both. One focusing on getting the patient back to a healthy These individuals often have chronic low self-esteem and of non-compliance. We don't like that word, so we also will say non-adherence, meaning that they're not following what the doctor has suggested or what would help benefit their disease process. And then, of course, due to the heaviness or the extra weight, they're not able to run that mile. It might be hard for them to walk 30 feet. So these are some things we might have to focus in on and help them be able to meet the goals. Your goals are going to be make sensible dietary choices, follow an exercise routine, relate strategies to deal with hunger. So what do you do when you're hungry? Oh, okay, I'm going to go walk around the block, or I'm going to go fold towels, or I'm going to go do something else. Give them something else to do to deal with the hunger. Have them identify something that they can do, because you really don't know what they do. But have them do something that's a healthier thing to get them away from the food. I mean to do that. Support groups. And then also we want to be able to measure a weight loss. We need to weigh it. Have we lost a pound? Have we lost 2 pounds? So we need that. You as a nurse are going to assess, you're going to provide caring interventions. You're going to encourage the client to identify the fact, a lot of discussion, contributing factors. You want to establish realistic goals like 2 pounds in a week, not 10 pounds in 3 days. And you discuss this with the patient. So you make the plan. And then you also get the balanced diet, what they normally eat and what recommendations work together. So it's a plan that they will follow. And then behavior modification strategies, what they can do. And of course, monitor weight loss, blood pressure, and lab data. Encourage exercise and promote weight loss. Identify any behavior modification strategies. If they're working or not, you might have to change those. And then have the client establish strategies for stress eating. That's what I needed, but I didn't. And then again, promote self-esteem, encourage client to verbalize experience, set small goals, offer positive feedback and encouragement, and refer to counseling as appropriate. So even if it's a half of a pound of a loss, still encourage, that's great, you've lost blah, blah, blah. You know, it's a little bit more of a challenge when they gain weight to give positive reinforcement, but it's all about, yep, this week wasn't so good, but you know what, we got next week to look forward to. So you want to keep it positive. You don't want to scold. You don't want to judge. You don't want to belittle. You're there to help them. So be that support for them. So your evaluation is going to be about your expected outcomes, and they could be as this is a few that they could say: identify and understand factors contributing to weight loss. And you'd want that to be done before discharge. Understands and applies behavioral modification techniques to lose weight. That you might have to follow up with in a couple of weeks. You might see these patients come in and out. So just depending on the setting where you're teaching or where you're dealing with. Another thing is the patient accomplishes their desired weight. I can't talk. And incorporates physical activity into routine. So that's what we're looking for. The patient doing this, then they're going to lose the weight. So that's kind of the focus of what we can do in the nursing world. I don't have time for the case study, but that's my references. But anyway, y'all go look at the notes. I don't know if the outline follows the notes exactly. I did shift a couple of slides around. It's all, if it's in your outline, it's in my PowerPoint. Look at the book. If you have any questions, send me an email. I'll post a discussion if y'all want to put questions there. But I like if you can send it in an email, however you want to send it. Let's see if we can clarify it. I'm here for you. I want you to understand this is not complicated. It's just a lot of information. Okay. And y'all have been eating your whole life. So you basically know what you need to do. It's just now taking care of individuals that have problems. And what can you do to provide safe care for these individuals that have difficulty swallowing or chewing or whatever. Y'all remember to always promote independence in no matter what it is you do. If it's eating, dressing, if they're struggling to put their sleeve on, but they can put the sleeve on, let them do it. You can assist them, but just don't take away from them because that's going to make them feel bad. Does that make sense?
Yeah.
Thank you. All right, so anything else?
Goodbye, Andrea. See you later.
Bye, have a good one. You poor students. Next time I'm gonna do it while I'm doing jumping jacks to entertain y'all. I'm sorry it's such a humdrum lecture, but it's important information.
No,
That's-
it was not humdrum. It was
It
a good
kinda
lecture,
is.
Andrea.
Oh, you're so sweet.
No, not it kind of. You know it.
The students, they all look asleep. I feel bad for them. Y'all go take a
I
little
know. I
nap.
see that.
Some of them are more awake and smiling, which is nice. Anyway,
My
y'all-
coffee has kicked in.
wait, say it again?
My coffee has kicked in. I'm good to go.
Okay, bye. I'm going to get
Bye-bye.
some. All right, you guys, I'm here if you need me. Have a great
Thank
day.
you.
Thank you, Ms. Duplechain.
Yep. Questions, y'all please ask me. I'm very approachable. Just
Thanks,
Come get me.
Andrea. That was a good
It was
lecture.
good. This was a good lecture.
thank you. I appreciate that. It's been a while since I lectured, so I was off last semester, so I feel weak, but I'll get it. I'll be all right. Y'all
See
have
you
a good one.
later.
Thank you so much for y'all support.
All right.
I'm ending. Bye.